Is there an action thing there, David?
Yeah.
Sweet. All right. So, welcome. Thank you for coming today. So, my name's Tony D'Ambrosis. I'm the CEO for CheckUP. And welcome to our quarterly events. And this time we're going to be presenting around our health services. And in particular, outreach and how we provide improve access to health services in rural and remote communities, which I think I'm quite proud to be involved in that and helping with that. And I know the team is themselves. I'm relatively new as a CEO, so 4 months in. Can I just say, just been really impressed with the skills, knowledge, and the hard work that the team puts into organising the outreach services. I come from a commissioning background in PHNs, and I can assure you guys have a very sophisticated model, and it's a model that allows us to review what's going into a region and pivot if necessary quickly to meet additional needs, etc. And I think that's unique to CheckUP, and I'll certainly push that. And in all honesty, I think that's an acknowledgement of the team and the work they've done to set that system up. It is unique to CheckUP, and I think adds a lot of value to how the services are provided out there. So that's the first thing. Second thing is just to thank the providers. So if there's providers listening online and in the room, heartfelt thank you to you all. I know you do get some financial support with this, but I'm sure there's a whole heap of heart and commitment from yourselves personally into this. And we thank you for that. And it wouldn't work without you guys and your flexibility in doing that and being able to move around and be flexible. I think it's really important to how we deliver the services. The final bit I'll acknowledge is the communities themselves. I get to meet some lovely people, great people out there, and work with a lot of diverse backgrounds, and it's enjoyable, but it only works because there's lots of flexibility within those communities as well. So again, thank you to those guys. The other thing I guess I'll just quickly say before I do have to summarise up so I can go into a few more details there, but I think the benefits of providing that access allows people to access services so that they don't escalate. We don't have to go to emergency departments, preventative care, and just the reduced costs and people not having to travel, the impacts on their family, the lost income to themselves. There are lots of benefits. And there has been a BDO assessment done a few years back, and I believe for every dollar invested, depending on the community, the return is about $1.32 to $1.92. So it's a pretty good return on investment around that as well. So I believe we do it very well. We collaborate with everyone, but the benefits to the community are not just financial, but also in the community themselves. So I'll stop talking. I could keep talking, but I will stop talking. And I'll introduce Elise, who's our general manager, and literally along with a few of the team, the brains behind the whole thing. So I'll get her to chat and we'll go from there. Thanks, Elise.
I hope technology works with this one. So thank you, Tony, and thanks everyone for coming today. So my name is Elise Gorman. I'm the health service, the general manager of health services at CheckUP. So I essentially oversee a team of 18 who do a fantastic job, I guess, in commissioning a large number of services across Queensland. So there's a number of the team members in the room today. So my presentation will be a quick, 10-minute snapshot, plus a video that's going to do the hard work for me. But if you are staying on for lunch, please feel free to obviously have a chat to me, or there's a number of team members in the room as well. Oh, sorry. So firstly, I'd just like to acknowledge the traditional owners on whose lands we meet today, and pay our respects to elders past and present. So we're currently on Turrbal and Yagara land at the moment. So thank you. I'm going to actually touch on that, so we won't go through CheckUP at the moment, but we did want to start the presentation just by, setting the scene. So today's, presentation is around healthcare closer to home. and improving access for health services in urban, rural, regional and remote locations. So we do have a short video that's just it's about 4 minutes that I'll play, and then I'll jump in and provide a bit more of an overview after that.
Yes, it is a very friendly town, Corby. We live in a remote area. Distance is a big thing. We do have a few elderly clients here, and they don't like to travel. Some of them aren't well. A lot of people don't know anything much about the city as well. That's really hard for bush people, I think, and especially Aboriginal people.
The Quilpie Township, approximately 550 people live here. We have a great community, good community spirit. We can't have every service here because it's obviously not financially applicable.
CheckUP's a not-for-profit health organisation. We're committed to creating healthier communities and reducing health inequities. And we do that by coordinating a wide range of health services, which are delivered in rural and remote Queensland.
The outreach program is making services that normally are out of reach for a lot of the families that won't have the funds to travel, or are too unwell to travel, or are unlikely to travel because they've got other barriers. The outreach program has removed a lot of those barriers for families.
It's good to have them here. If we have to travel to Rome, that's 3 hours away, and that's 6 hours out of your day. If we can get the services here, then it's better for us, I say.
We know that our remote and rural Australians suffer poorer health outcomes than those that live in cities. Our remote Australians deserve good healthcare. There's no reason that when the country needs them to be in the remote areas to put food on our plate and to keep the country going, that they should have to suffer less access to healthcare because of it.
We have about 120 referrals that we're working with at the moment, so pretty busy time for those specialists that visit here. We have a lot of helplines and all that sort of stuff, which are good, but having that face to face it's like gold to these people in the bush.
When a patient knows that there's a doctor, a nurse, a pharmacist, a physio that's actually committed in a long-term sense to providing care in that community, it's like a sense of relief for them, because they know that they're not going to have to repeat their story. They know that that particular person's invested in them and the community, and it means that they're going to get better health care.
For the last 11 years, I've worked as a podiatrist and been providing outreach services to Quad 6 in Charleville, Roma, Mitchell and Quilpie. What I enjoy doing is getting to know people and building a rapport with them.
We have a lot of providers who have been going into these same communities for many years. So they build a rapport with their local community, with the local health service. It's more about building connections with health providers in these rural and remote communities.
I think the CheckUP of supporting us to go to locations wasn't just about us providing a psych service, it was about building the capacity of those communities. And we found that was in professional development, workforce enhancement, self-care.
When we are looking at providers, we offer them support and collaborating with them, linking them in with other providers, linking them in with our host facilities. We offer them training. It's really important because we need to support them so they do stay with us long term.
By getting to know people better as a regular clinician allows you to better understand the needs that the individual may have to help them get the best health outcomes that they can.
Really, it's about continuity. And this is where CheckUP is incredible, is that the service needs to be ongoing for the community to form that bond and trust with the clinicians and feel comfortable coming and talking to us about really sensitive topics.
Born and bred in Winton, Queensland, and with driving trucks, I got the pleasure of coming to Charleville about 1986. I had a bit of a mental problem there 18 months ago, and it wasn't no fault of anybody. Ed, he was just unbelievable. Very caring bloke. We are blessed out here in the West. to have people like that.
When we see the difference that these health services make to people's lives, that's incredibly rewarding. It's extremely satisfying. We know we're doing a job that does make a real difference in people's lives.
So this video and also a number of other videos are on CheckUP's YouTube channel if you'd like
The
to.
easiest way to test a nonstick
see a
is
few
to
of those.
connect. Now look, check out that.
It's really nice when we do, I guess, see these videos. Is sometimes we work with a lot of spreadsheets in the office. We see a lot of service providers' names, contracts, as you could imagine. We contract 190 providers and organisations. So we find when we go out to communities and we can get to talk to patients in videos like this, it really sort of brings it home in terms of why we're doing what we're doing. And that it's not just a line on the spreadsheet, which, yeah, is always very fulfilling.
And I can certainly speak to that and endorse what you say, because I'm from Charlton.
Yeah.
And I used to work for
Yeah.
So I recognise
You know a few people.
A lot of the people. I'm like, when Pete was walking with his, I'm like, yeah, there's Troy. But being on the ground and seeing how impactful that is and how life-changing that is, as Pete said, sometimes they're very fortunate to live out in the West, despite all the challenges.
Yeah.
Being able to have that sort of support so people can stay at home.
We see a lot of service delivery reports from our providers that deliver the services, and we've actually got 5 of those reports due this week, and part of those reports are good news stories, and it's looking through all of those visits, so confirmation to the providers that we do read them, and we do share some of these good news stories as well. But even just last night, and I've been doing this for a long time, there's some good news stories from a patient level, but there's also from a provider fulfillment level as well. So there is a lot of commitment from our providers, and there's a couple of slides that show you how long some of these providers have been going to these locations, but they're still seeing new things. Like I just read last night that there's an optometrist who I think saw a 6-week-old baby, and that was something new for him. And, you know, just stories like that, you kind of think, okay, well, would that child have seen an optometrist if there wasn't one in community? So it does really sort of bring it home, those stories, and we do read them. So if you are a provider in the room, I know there's a few of you there, we do. I won't go into this too much, but essentially what is an outreach service? So it's bringing a health service or healthcare to the community, instead of the community having to travel to receive that service. So it generally involves a health professional leaving their day-to-day practice and their, I guess, base location and travelling to deliver service in another community. So it's all about healthcare close at home. And I do like to say that an outreach service is more than just a visiting service or a FIFO service. These services have been going to some of these communities for a very long time. So they're very much well integrated. The community knows them, and they don't see them as a visiting service. They see them as the service. So I do like to mention that. Why they're needed, I won't go into this in too much detail, but essentially there's some significant barriers that outreach services, I guess, overcome. In these locations, if these services weren't going to these communities, they'd have to travel long distances. There would be significant cost travel if you're thinking, parents taking kids out of school, multiple flight tickets, costs, etc. Not to mention the coordination involved in that. And we do hear quite often, I guess, in just even trying to access a service locally, there could be 4-week waits, 6-week waits to get in to see their GP. So, these services do, I guess, bridge a gap. We'll go into more detail. So what does CheckUP do? So we're a Commissioner of Outreach Services in Queensland. So we essentially contract health professionals, or we identify needs and gaps, and we contract health professionals to go meet those needs in those locations. So we've been doing this for over 25 plus years. So we're, I guess our focus has been on improving access to health services for quarter of a decade, essentially. We have been the Queensland fund holder for the Australian Government Department of Health, Disability and Ageing outreach programs. So there's a suite of those programs, which I'll flick onto in a couple of slides time, but we also received some funding from Queensland Health, PHN's, the Fred Hollows Foundation as well. And we actually got a few of those presentations today to tell you more about those programs. So these are the programs that I guess help bring healthcare closer to home. So these are the federal department programs. So I won't go into each individual detail, but essentially each of the programs have very different priorities, health priorities, and also priority populations as well. So there are obviously particular guidelines that we have to follow in delivering these services to meet the different program requirements as well. If you've been in the space for a little while, you would know our MOICDP and our Healthy Years programs. So this year they actually just combined to the First Nations Health Outreach Service as well. So same priorities, just a merging of the two programs into one. These are our, I guess, Fred Hollows Foundation, Queensland Health, Country to Coast and North Queensland Primary Health Network programs as well. Again, all focusing on improving access, just slightly different health priority areas as well. So there's quite a bit of information on our website if you'd like to look into more of these, or just speak to a member of the team and we could probably decipher the differences between each. So our reach. So just last year, we supported the delivery of services in over 170 communities across Queensland. So those go right from the Torres Strait down to the New South Wales border, out to the Northern Territory border as well. So that map, I guess, shows quite a number of those service locations as well. So we've got quite a good reach across Queensland. We contract 164 providers. I think this year we're looking at around 190. So as programs come on board, our provider pool is growing and our network of service providers and facilities also supporting continues to grow as well. But we essentially support 1,600 services and just over 18,000 visits last year, which generally sits around 190,000 occasions of service provided, and around 60% of those provided to Aboriginal Torres Strait Islander patients as well. So I like to look at those numbers and think they are individual patients not having to travel. Because if you do the sums, and even if you think of $1,000 per trip times that many occasions of service, it's a lot of money, not to mention all the other inconveniences and time and logistics involved in that as well. So stats are great, but the picture that sits behind it tells more of a story. So there's some of the services, types of services that we support. So it ranges from specialist GP, allied health, nursing, pharmacy, Aboriginal health workers. It could be scientists, coordinator positions. So it is really the whole spectrum. Our funding eligibility. So we support the out-of-pocket travel expenses to get a provider from their base location to their outreach location. So when they're actually in community delivering the service, we require them to bill MBS. So essentially most of the costings are flights, meals, bit of admin support, mileage, and then the rest is MBS billing. We are able to fund the upskilling of local health professionals while service providers are in communities. So we do encourage our contracted providers to speak with the facilities to see if there's any upskilling needs that they can support. We do support, that could be a lunchtime session, or it could also be a formal workshop or a community event. It's really quite open. And we do support their time in delivering that service as well. And probably just to add, we do support face-to-face and telehealth, so mixed models. Outreach providers. So last year it was 160 individual providers and provider organisations that we contracted. This year it's looking at around 190. In terms of these services, not just being a FIFO service or a visiting service, so 40% have been delivering services for 10 plus years. So they've had quite long-term contract arrangements with CheckUP, and also relationships with these communities and with these patients as well. So we don't chop and change providers. We certainly refine, and if we need to revisit how we're contracting or redesign services, we do that. But essentially, if the community's happy, the facility's happy, the provider's happy, then these services will continue unless there's a reason that they don't. In terms of providers, they range from Aboriginal community controlled health organisations, HHSs, not-for-profit, and also some private provider organisations or individuals as well. We also couldn't do what we do without the support of our host facilities. So a number of these facilities, they don't charge facility fees. They see the benefit that these services are providing to their patients and their communities. But we do go into over 300 of those facilities, and they range from there. So depending on the service need identified, it could be a mobile service, it could be a daycare screening service, could be in a general practice community health centre. Some of these communities, you don't get many options. It is the community centre, the PCYC, so it very much depends on the community and the needs that we identify. How we do it. So this looks like a very simple model, but a lot sits behind each one of those little squares. We've essentially got a 6-step commissioning cycle. Service planning obviously commences. Our service planning process is continuous. It is not at one point in time. It's ongoing. We identify needs and gaps and emerging needs and priorities. If you think about in these rural and remote communities, a family could leave community for a number of reasons, but then you've lost your GP and you've lost your podiatrist. So obviously then needs emerge throughout the year, and our model allows us to respond to that. And I'll go into more detail in just a sec. But essentially we identify needs and gaps. We design services with community and with key stakeholders, recruitment and contracting, service delivery and service monitoring, performance management and service tailoring and evaluation. And Philip is here today and she's going to wrap up today's meeting with some evaluation information. We also have our regional engagement framework. So CheckUP's got I guess our central office is in West End, but we've also got an office in Townsville and in Cairns. And we've got 4 regional coordinators that are located in Cairns, Townsville, Toowoomba and Brisbane. Essentially, they are the eyes and ears on the ground in terms of being the key contact for stakeholder engagement. So that might be providers, host facilities, community members, other key stakeholders. They really understand, I guess, that local intelligence, and they're the ones, I guess, who would be your key contact if you're interested in supporting a service in those regions. So they're our CheckUP regions. So they align with the HHS boundaries and referral pathways. The other, I guess, unique thing about our model is we don't block fund. So our providers are paid on a per visit basis. So once a visit is delivered, the provider submits a report online, provides some service delivery details, and then we make payment on that. We've got a system that essentially allows us to have amazing oversight at a visit, service, stage, regional, whatever level we want, to be honest. But it allows us to track service delivery over time. So if you think from a contract management perspective, we can see how providers are tracking in contracts. They can communicate to us in terms of, okay, there's a weather event, I wasn't able to go that day. Can I vary the contract? Or seeing large wait lists, could I have another visit? We are able to respond to that because of that service model, because we can see money going out the door and what money isn't. So that provides, I guess, a level of oversight, flexibility, but it also allows us to respond quite quickly to certain events, knowing that we've got funding available in those areas as well. So that's it from me today, but there is a lot more information. I could talk forever, but please stay for lunch and have a chat to myself or another member of the team, or email us on our outreach service email. And also CheckUP's website has a lot of information as well. So I'm going to hand over, I think, back to Tony. So we've got a number of, I guess, presentations today. A few different formats. We've got interview style. One of our outreach providers we'd asked to present, but they're actually on an outreach visit, so they've actually recorded a presentation for us. So we've got that, and there's obviously a number of videos as well that we're gonna go through. Do you want me to introduce them? Yeah.
bouncing backwards and forwards. So first presentation is going to be from Amber, who is our eye and ear surgical services manager. So Amber has recently stepped into this role and has moved up from an RC role and taking it on. Amber brings her analytical skills and leadership experience from the PHN, funded rural primary health service to her new role. So she was in their regional coordinator for us. So has stepped up and shall we say it's a challenge. Thanks, Amber, for helping us out.
Thanks, Tony. As Tony said, I am Amber. I'm the surgical service manager here at CheckUP. But prior to June, I was the regional coordinator for the Central and Central West region of Queensland, which is how I became involved in this program. So today's theme is improving access to health services for regional remote Queenslanders. And for me, this project is a great example of what can be achieved when organisations work together towards a shared goal. When the Western Queensland PHN established the MDT program with a focus on diabetes education, they brought stakeholders together to collaboratively design and deliver the service. I was fortunate to be invited to these meetings. Western Queensland PHN and CheckUP work closely together because many of our providers we find are the same. There's not many choice when you're in Central West. So by maintaining transparency around our funding and priorities, we can avoid duplication, align our efforts, and maximise the benefits for communities. Through these discussions, providers identified barriers to integrated care, including different systems, referral pathways, and limited opportunities to work together in the field. A common message was that spending time together in community would help strengthen relationships and improve coordination of care. So when funding became available through CheckUP, we saw an opportunity to support a charter flight that would bring providers together, and we put the idea into practice. The charter flight wasn't about just about transport. It was about building relationships, strengthening referral pathways, and creating a more connected service system so that people living in regional and remote communities can access the coordinated care they need. It's a fantastic example of organisations working together, not duplicating services, but leveraging partnerships and funding to achieve greater outcomes than any one organisation could deliver alone. As Lise was saying, unfortunately Sarah could not be here today as she is currently on the road from Longreach to Mount Isa. However, she has pre-recorded a video showing more about the MDT program and the outcomes of the charter flight.
My name is Sarah Bowen. I'm an allied health manager from North and West Remote Health. NWIH is a not-for-profit organisation that delivers healthcare services to remote and rural communities across Queensland. We deliver allied health, mental health, wellbeing, care and aged care services to over 50 communities and have done so for more than 30 years. These are place-based and outreach services. I'm really pleased to share a presentation today on connecting communities through collaboration, which will talk about a multidisciplinary diabetes outreach service being delivered into the Western Corridor. I'd like to begin by acknowledging the traditional owners of the lands we are meeting across today. I'm currently on Iningaya country in Longreach. I pay my respects to elders past and present. I recognise their continuing responsibilities and connection that First Nation people have to land, waters and sky, and how sacred this country is that we stand on today and the thousands of generations that have come before. This beautiful artwork that I'm sharing was created by an artist, Auntie Opunda Jean Barcrombie, a Wankangaroo Yaru Yandi Aboriginal woman who is based in Birdsville. The artwork was commissioned as part of our diabetes project and is titled The Travelling NWIH Women. There's 3 circles representing Mount Isa, Bedourie and Birdsville, and the connecting path between those circles is around what path is taken to deliver healthcare services between these communities and the connections that are between them. The collaborative program I'm sharing today is a multidisciplinary team diabetes program, and it's funded by the Western Queensland Primary Health Network. It has been commissioned as part of their commitment to improving access to integrated care across the region through their wonderful Healthy Outback Communities initiative. This program is one of many initiatives that sit within. Your postcode shouldn't be a barrier to accessing quality healthcare. However, health disparities that exist in rural and remote communities is quite dire. I'm sure most of you dialing in would know this already. So just a very brief background to share that people who live in remote and very remote Australia are 1.3 times more likely to have diabetes than those in major cities. 25% of all potentially preventable hospitalisations in the Western Queensland region, so Birdsville, Baduri, Booyah, Stonehenge, Junda, Windora, are due to preventable diabetes-related complications. 19.4% of this region identifies Aboriginal or Torres Strait Islander, and First Nation people are experiencing a higher burden of type 2 diabetes, an earlier onset and a more severe disease progression. The current challenge of delivering multidisciplinary care into the Western Corridor is really about the geographical distance and the service region being really vast and significant. Geographical isolation interacts with health literacy and compounds the ability to access health education and to participate in healthcare journeys. People face high demands to find and access and use distant health services, which impacts system navigation as well. The transient nature of the region, but also the transient nature of the workforce delivering care into this region. There's a real maldistribution of this health workforce, and this impacts the ability to build local capacity, to build trust and community connection. These services are often fragmented, provided by multiple service providers who may not communicate, may use different systems, and may not have the data to share between one another. People can then share their stories over and over again, placing the burden on the individual accessing care. This means a real misalignment to goals, to care and providers. The MDT Diabetes Program aims to support people living with diabetes within the Western Corridor region through a coordinated approach. This is around enhancing support and existing care, not about replacing the strength that exists already within the system. The program supports coordinated approach for those with chronic disease, strengthens communication between providers, reducing duplication, aiming to reduce service fragmentation as well, supporting shared decision-making through aligned patient goals and improving overall management by measuring outcomes and increasing remote patient monitoring, and an overall aim to reduce preventable hospitalisations with improved diabetes care. The following are partners in this program, so Diabetes Australia, the Western Queensland PHN, Lives Live Well, Central West HHS, NWRH, and the Royal Flying Doctor Services. As shared, for the model of care is really that collaborative team approach. So this is about shared trips and itineraries where possible, case coordination, service coordination, and conferencing between providers, localising services, so ensuring that care is delivered as close to home as possible with a regular team, the collection of client and health outcome measures, so measuring what matters, following value-based healthcare principles to ensure that the services are actually achieving meaningful outcomes, utilising technology such as CGMs for remote monitoring, providing culturally and geographically responsive care, so providers and communities are working on locally led initiatives, and making sure that offering mixed modalities occurs, so face-to-face, group-based intervention, telehealth, telephone, remote monitoring, and aiming to build a real sustainable diabetes care team through providers collaborating together. The initiative isn't a standalone, it's about becoming business as usual. There's some really wonderful collaborative initiatives coming from the program. So this includes a health passport check, where health checks are monitored. There's an agreed frequency, and it ensures that there's an annual cycle of care being completed. Providers can sign off this, and patients have access to that information. There is group-based education as well. Some group-led initiatives include a walking group, a diabetes class, and some cook-ups as well as access to mental health support through Lives Live Well. I want to share a little bit more about what a collaborative team care approach looks like in a practical sense. So collaboration together looks like 3 different organisations jumping onto the one plane. This is about coordinating services together, coordinating an event, coordinating engagement with the community, a coordinated visit to local primary healthcare centres, having shared goals and shared outcomes. So we were able to do, thanks to CheckUP, a visit all together, enabling joint travel between 6 different remote communities, a true MDT approach to outreach, an efficient use of resources and greater value being offered to communities. This means that there is a reduced service fragmentation and there's opportunities for collaboration that would have been missed out otherwise. So we had 2 trips to 2 different regions, Junda, Windora, Stonehenge in April, and in June, Birdsville, Baduri and Booyah, where a diabetes educator, podiatrist, a clinical lead, counsellor and project evaluation were all involved in coming together. During this initiative, there was health service engagement, discussion of referral pathways, introducing the program and the shared program resources, as well as a really fantastic community engagement session where we hosted a sip and screen event, which was a draw card to the community. We collected information on what matters to me. We provided free health screening and health checks, as well as diabetes education, and used the different skills of the providers all together at one time. There were 53 people who were seen through the health screening, as well as a diabetes clinic, which would normally not have ran, which provided increased access outside of their usual schedule. As well as these outputs, there was actually some tangible outcomes as well. So it's really important to hear from the community about what matters to them, knowing what health services are coming and where they're available, how to access fresh food, health checks, and feeling confident about managing their own healthcare were some of the themes that came out of it. The day was challenged though. There's a small number of people. Continued engagement is obviously required, and being able to troubleshoot and be prepared for anything such as no power and no services as well occurred on the day. These 2 events are really just the start of putting the program together. We now have participants registered in each community, case conference is commencing, and there's a suite of documents ready to support. The enablers of seeing people together, leveraging off strong partnerships of one another and co-creating services together is fantastic. We now have an itinerary with the next 6 months where Diabetes Australia, Lives Live Well and NWIH are working to travel together, working with RFDS to further improve coordination and communication together, and really making sure that we have shared resources and better collaboration between everyone to partner and provide access to these specialised diabetes services. If you are interested in knowing any more about this project, please email us on the project email provided below. And thank you so much for listening today.
Over to you, Tony.
Rightio, I will get on the right page soon. Goodness me, my apologies. Getting there. All right, so up next, let me get the right glasses on. So, Marianne, perfect, in the room, and I have crosses out here, so this one is not on me. And is Kathy here as well? Oh, yeah, perfect, wonderful, lovely. All right, so Marianne Calder is a dedicated project and programs manager with wide-ranging experience in the not-for-profit health and community services sector in Queensland. Marianne currently manages CheckUP's cancer prevention programs, which includes the SCAD program. I'm sorry, I can't expand that acronym, but I'm sure Marianne can. There it is, Skin Cancer Early Detection, and a North Queensland PHN Cancer Prevention Program, which is increasing access to skin and cervical screening services in far North Queensland. Recently met with Matt Smith up there, the MP for Leichhardt, and Marianne has just been busy as a bee and rolling out a heap of great work up there. So I can definitely account for that. And Kathy has a welcome. Has a long career leading health promotion programs and projects. She joined Queensland's Health Prevention Strategy Program in 2007 and has worked there on and off. In 2022, Kathy commenced a role leading the 4-year funded skin cancer prevention and early detection project. This project prioritises rural and remote regions of Queensland, and Queensland Health contracted CheckUP to deliver the early detection of skin cancer service. Kathy describes working with CheckUP as one of the great pleasures of her recent work life. That's what happens when you're in. So, thank you guys. I'll leave it with you.
Hi everyone, thanks for coming today. Thanks for that, Tony. First, on behalf of Kathy and myself, we would like to acknowledge the traditional owners of the lands on which we're all meeting today, both here in Meanjin, in Brisbane, but also wherever you are at home or in your offices online. Thanks for coming. We also pay our respects to elders past, present and future leaders. Kathy's going to get a bit of an introduction to how we came about this the Skin Cancer Early Detection Program, or SCED, as it's fondly called now, after 4 years. And yeah, we'll just talk you through, I guess, not just the outreach component of this particular program, but also the upskilling component, which we've been able to incorporate over time as well. On to you.
Morning, everyone. That was a tough act to follow. That was an impressive presentation we had before. So thank you for the opportunity to speak here today. I'm coming from a sort of the perspective of someone who was asked to do something and then was how do we address that? So when I started working with Queensland Health, there'd been a recent announcement by the government that there was going to be a 4-year investment into skin cancer, and as part of that, there was going to be more promotion around to help have better behaviours, but also it was mentioned that there'd be pop-up clinics. And one of the reasons for that is because Queensland does have is the sort of world capital of skin cancer. You can see this from the graph there that Australia has the highest rate of skin cancer in the world, and Queensland's much higher than Australia overall. So, and approximately 2 in 3 Australians will be diagnosed with skin cancer. And there had been a number of campaigns over years, but then we'd had a bit of a delay and we weren't necessarily seeing continued improvement in sun-safe behaviours. So that's partly why this was announced, but it wasn't necessarily something the department had been saying, hey, we need this. It was sort of an opportunity that was given to us with some parameters around it. As well as that, we wanted to, I suppose, just flag before we get started as well that with outdoor workers, there is that increased risk because you're spending so much time outdoors. Often get 5 to 10 times as much UV as other people. So and also many of those people are in rural and remote areas. And then we do know that accessing a GP with experience in skin cancer is really limited, and particularly in rural and remote areas. So that's just a bit of the context. And then I launched straight in here, and we'll go to there. So this was a commitment with this boost. What was interesting about that was, and what was really helpful, was that in Queensland Health there had been a policy network that had been established many years ago called Skin Cancer Prevention Queensland, and that brought together researchers and the Cancer Council and all other people working in that sector. So when this opportunity was presented, we were able to go back to experts in the field straight away and go, how does this sit? What's this? And then we're like, and screening was also mentioned, like, no, we don't want to do screening. That's not really the most effective way to go in this space. They were able to give feedback straight away that where the gaps were in rural and remote Queensland, and was in people being able to access the full range of services, and highlight that there's no point turning up somewhere and doing a pop-up thing and saying, you've got a problem, you need to see someone. Well, where is that someone that you're going to see? So it was a real opportunity to dip into that network, and that network of people was then able to come and be part of the steering committee to help guide the whole process. So it was a really, some people said it'd be really helpful to just do more training rather than deliver services, but that wasn't part of what the package was. The package was we need to deliver services, and then it was like, well, how are we going to do this? Queensland Health doesn't normally do those sorts of things. What are we going to do? We did a bit of sort of scrambling around and looking, and then of course hit CheckUP and spoke to Elise, which was fantastic. And we identified that the model of outreach services that was already being funded by the Commonwealth was a sort of thing that could happen in this sort of context. So we're able to sort of start moving from there and develop a partnership and a way to really deliver something that was meaningful rather than just a short-term feel good hit, but that didn't. We wanted to have people better off as a result. So the aim was to improve access. We didn't think we'd cover the entire state with the funding that we had, so we prioritised 5 hospital and health services. They were ones that had they were rural and remote primarily. Later on, they said, why didn't you include Central West? And it was like, well, but we've been able to learn through this whole process as we go. And so we contracted CheckUP and got the delightful Marianne.
Lucky you. Okay, let me tell you a little bit about the SCED outreach program and how that all works. So this program, it's GP-led clinics. Basically, as part of our clinical governance, any of our providers have had to provide evidence of their experience and or qualifications in skin cancer medicine. These providers, as Elise has mentioned, they travel to communities basically to deliver clinics. So they're usually locations that have either 1 or no doctors, or potentially there may be 1 or 2 doctors, but they're at capacity and or don't have qualifications specifically in skin cancer medicine. In terms of initially identifying the locations where we were going to deliver these clinics, there was a lot of consultation done within the 5 HHS regions, primarily through the GP liaison officers within each of those regions. They're incredibly helpful people. They know their regions really well. They can tell you exactly what's happening within their GP networks, and definitely worthwhile speaking to them, because whilst online you might go, oh, there's 3 clinics in town. They look like they're okay, but then when you dig a little deeper, you find out that one clinic's about to close because the doctor's retiring. Another one flies or does everything online and is based on the Gold Coast. And the other clinic, yeah, they've got a couple of locums coming in every other week, and they don't do skin because they're not confident to do that. So that's how we basically identified our locations. We have 3 service providers with this program, RFDS, who everyone has heard of. They basically work in locations where there is nobody. There's no clinic, no doctor, no nurse even, and they often will set up a room in a town hall, fly in and see their patients there. Another couple of providers, one who flies doctors out of Townsville up into the northwest, and they work in Corumba, Burketown, Cloncurry, Normanton, very isolated communities with a lot of skin cancer. And we have another provider based in Brisbane, Skin Patrol. He's done a couple of other regions for us as well. He's done some clinics into Mackay and Central Queensland. So at these clinics, basically patients are offered a full body dermoscopy, and any investigation can be done on the spot. So any biopsies, excisions can be done there at that appointment, and or patients come back at the next visit. I guess that's the beauty of having GPs who are specifically trained in skin cancer medicine. It's kind of like a one-stop shop. It's not like you've got, oh, there's a couple of things here, you need to go into whichever regional centre to get them sorted. So that's been really great. And over the last 4 years now, we have provided these services into 18 different communities across Central Queensland, Mackay, Townsville, Northwest and Southwest HHS regions. Here's a map, so it gives you a little bit of an idea of the spread. So as I mentioned, 18 communities where SCED clinics have been delivered. 187 clinics since the program first started back in, I think that was around May, June 2023. Over 4,000 patients have been seen, which is over 4,100 occasions of services or appointments. Just under 2,000 people receive pre-cancer treatment. So that could be anything from a topical cream to cryotherapy to biopsy excisions. Of those, 774 had histologically proven cancers detected, so around a fifth of everyone that was seen. You can see the skin cancer numbers there, they're pretty impressive. 607 BCCs, 502 SCCs and 51 melanomas, of which 10 were invasive. So they have a pretty good hit rate when they're out and about, our skin cancer doctors. In terms of patient feedback, we started collecting that probably 2 years ago. I think we've had just under 200 feedback surveys come in. It's all been very positive in terms of the feedback from patients. consistently is they're just so pleased that someone has come to town and they're able to get their skin checked. As with all outreach services, there's the usual barriers in terms of trying to access a service, and particularly a skin cancer doctor. People are having to travel, as someone mentioned, up to 6 hours return trip to Townsville to go and see a skin doctor. You know, they put appointments off. There's a lot of elderly people as well living in a lot of these tiny little communities. They're no longer driving, and they do say, like, if you weren't coming to town, I think around 25%, 26% say they just wouldn't have their skin checked. It's just too hard. But of course, with outdoor workers, you've got people living on properties. It's very hard for them to get away from the farm and into a larger centre to get their skin checked. So it tends not to happen. As part of the program too, we've really encouraged our providers to, whilst they're there obviously doing their skin checks, just to talk to people a little bit about, I guess, the risks of skin cancer, sun-safe behaviours, that kind of thing, trying to increase their knowledge and awareness around self-skin checks. So that's been part of this program as well. Yeah, so that gives you a bit of a snapshot in terms of how patients have responded to the service. Upskilling opportunities. So whilst this is an outreach service, we were really lucky in that there were a couple of opportunities where there was a little bit of underspend for different reasons. And so we've really looked at opportunities to upskill local GPs in communities in skin cancer medicine. As Elise has mentioned, there is the opportunity potentially with some of the outreach providers when they're actually delivering their visit, if there's staff available and keen and interested, they will do a little bit of that incidental upskilling, and it might be just they've got a trainee doctor who's in the practice, and they might come and just watch them perform excisions and that kind of thing. But what we've also tried to deliver as well is some real learning opportunities for GPs in communities to improve not just, I guess, their knowledge and skills around skin cancer, but also their confidence. We know there's a lot of international medical graduates in particular that are practicing in our rural and remote communities, and a lot of them just don't have that foundation training in skin cancer because they just haven't done it. So in 2024, with some underspend, we did deliver 5 face-to-face full-day workshops in Rockhampton, Mackay, Townsville, Roma and Mount Isa. We had 98 doctors attend those workshops, which was really fantastic. We also had, I think, a pharmacist, and we had a couple of other interesting, a couple of nurse practitioners as well who came along, which was fantastic. In 2025, again, with a little bit of underspend, we co-sponsored some scholarships with the Skin Cancer College Australasia for 14 doctors to complete a certificate of dermoscopy course. We had over 70 applications for those 14 places. So my point being is that there's obviously a very high level of interest and demand for upskilling in skin cancer medicine. And we're now at a point with an additional year of funding. So the program was due to finish 30 June this year, but Queensland Health have very kindly funded us for an additional year. We will still deliver some outreach services. We are starting to transition those to other funding sources where we can, but the focus really for this next year is an upskilling of GPs. And so Kathy's going to tell you a little bit more about our Skills in Skin Cancer upskilling program and what that involves.
And part of this is because of that steering committee that I mentioned, and a number of those people are on the sort of the national roadmap for skin cancer, for melanoma screening, and so really high profile. So the opportunity for them to be hearing about what it's like in rural and remote areas, with Marianne presenting and talking about it, was really helpful in terms of people understanding the gaps there. Because from their perspective, well, the feedback that we got as we were looking at the feedback from the programming and doing an evaluation about what had been achieved and what are the long-term things, because our challenge was, of course, that we weren't given ongoing funding. It was a limited opportunity, but how do we better understand what the context is and to better serve the community in the longer term was what we were facing. And the feedback from those people was particularly that everyone should be able to see a GP with a good level of understanding of skin cancer. And so that was what we're aiming for now. So we're able to move into this next iteration in thinking, how do we transition both from providing the services, but also thinking about that skills of the workforce. And so to share some of that data with people and to think about sort of other funding sources. So the pleasure, again, was to be able to have the chance to work on those relationships. So Marianne had existing relationships. We'd worked with the college and with others for a bit and looked at, well, how might you address something like that? How might you think about upskilling? Having had the experience of having 70 people applying when we had 14 places before, and knowing the level of demand that was out there and knowing who we wanted to reach, it was challenging to think about how do we do that. So first of all, who's going to provide the course? And so we needed to go through a process there of thinking about what could be offered that was appropriate both for general practitioners but also nurse practitioners, so that it wasn't too limited. So a request for offer was put out and we got in applications from 3 different providers that we knew of who could do upskilling for GPs. So if it was really important that it wasn't a dermatologist-led type thing, with GPs being, oh, we'll train you enough to be able to refer you to a dermatologist. Well, we know that there are 6 outside the southeast corner of Queensland. So we need to think about what was relevant for the workforce here and what worked. And we also were able to tap into people to get a really, both from the steering committee and others in PHNs, to look at the applications and how we're going to select the right provider to be a flexible approach to Queensland. And through that, we did select the Skin Cancer College of Australasia. Also had other excellent applications, but that putting out that challenge for how to do a bespoke model and how to think about what's the message that you're providing here, because the message needs to be that GPs can do this, as opposed to GPs are a referral agent, because that just doesn't work. And implicitly in some of the ways it was said, we felt that was an underlying message. So then having selected the provider and what was going to, and what could be offered, we want something that was flexible enough as well, so that could be upskilling at a general level, but then this provider was able to say, well, if we've got someone that's already here, maybe we can help take them there. And so again, that sort of flexibility. Marianne worked then with the networks that were already developed through the commissioning model, particularly the GP liaison officers, to say, look, where are the gaps in your HHS? Who would be interested in doing some upskilling? So rather than go directly out to all GPs, we went and messages were sent to the GP liaison officers to say, who would you like to do this? Who's going to make a real difference to your community in terms of access? And we did it that way. So there are only 30 places. No, keep going the wrong way.
It's worth mentioning there's 3 different elements to this program.
That's
as
true.
Well. So,
Good point. Thank you, Marianne. Yeah.
From our learnings, I guess we've done bits and pieces. We've done workshops face-to-face, which are really popular. We've done, the certificate program, and they're all great in isolation. But the thing is, people need that ongoing learning, and they need the ongoing support and mentorship. So mentorship is another element of this.
True. Yeah, which again was different and built in, and again through the discussions and the feedback. But that sense that not just us that care about this, there's the wider network of people that really want this to succeed, I think really makes a big difference. It's only closed just recently. These are the ones that were sent out. Fortunately, we only received about 40, didn't we, for the 30 places that we got, or maybe a little bit more. So we've been
we were delighted with the applications we got there.
Yeah.
If I could have handpicked the locations and the doctors, I would have done so. I was like, great, we've got Thursday Island, we've got, Wallumbilla, we've got Julia Creek. Yeah, we've got a fantastic spread. So we're really happy with where we landed.
So I'm not going to go through all of that. We 2 more minutes. Well, that's pretty much it actually. Now we'll move on to the other thing that Marianne's doing. Thank you. Thank you.
Thanks, David. Yes, and just to wind up, that's the SCED program. I'm just going to tell you a little bit about a new cancer prevention program that we're recently being funded to deliver by North Queensland PHN. It's a cancer prevention program really focusing on increasing access to both skin cancer screening or early detection services, as well as cervical screening. And it's been delivered into both the Cairns and Hinterland and Torres and Cape HHSs. It's got a few components to it. There will be outreach for both skin and cervical screening. We're doing some upskilling with that program as well. So in terms of skin cancer, there's a local skin cancer doctor who's delivering some training up in Cairns at the moment. We're administering the bursaries for that training. We're looking at doing some increased upskilling of particularly Aboriginal and Torres Strait Islander health workers and health practitioners, where we can support that in cervical screening, knowing that Aboriginal and Torres Strait Islander women generally are more underscreened in terms of the cervical screening. And we're also looking at funding some health promotion opportunities within the ARCHOs and within local communities around skin and cervical screening. And that's it. Thank you. Thanks for listening.
Thanks, Marianne and Kathy. As you can see, great program. What I particularly like about that is the upskilling and future-proofing it and carrying it out, which I think is a great piece. So even if funding doesn't continue, there's still scope to move it along. So well done. Okay, up next, I believe we have Michelle and Nicole and from Gidgee. Welcome.
Yes, thank you.
And they're going to talk about eye health coordination in the Northwest. Did I get the right region?
Yep.
Beautiful. All right. So Michelle works for us. Michelle is Senior Manager for the Outreach Programs and CheckUP. Michelle has decades of experience in human services and is passionate about improving how we create a meaningful social impact that moves the dial on complex social issues.
That I am.
There we go. Learning lots every day, Michelle. Michelle's career spans roles within government, not-for-profit and private enterprise, working with First Nation communities, people with disability and within research and evaluation. Michelle is a values-driven systems thinker, adamant about keeping the people and communities we work with involved at the centre of what we do. All right. Well, Nicole has worked as the eye health coordinator with Gidgee Healing for 6 years, providing eye health services across 4 remote Aboriginal communities within Gidgee Healing's extensive service footprint in the northwest and lower Gulf of Queensland. How was the flight down?
Good. It was actually a lot quicker than flying to all the locations
Not
in the
bad.
Gulf, so yeah, it's great.
I'm going to go to Mornington Island soon. It's taking me forever. I will. Nicole's role includes coordinating optometrist clinics, providing eye screenings, imaging, booking appointments, arranging patient transport, ordering glasses, and providing glasses fitting and repair services. Nice. So, hand it over to you guys. Thank you.
Thank you, Tony, and thank you everyone for joining us. I'd like to also open by acknowledging the traditional custodians of the lands on which we're standing and gathering for today's presentation, and to pay our respects to the elders of these lands, past and present. I would also like to extend a warm welcome to Nicole. Thank you for coming all the way down from Mount Isa to present on the Regional Eye Health Coordinator role. Thank you. Because we've had a little bit of a summary about who we are and what we do, I will let Nicole talk a little bit more about her role. But just as a bit of a start and overview, the Regional Eye Health Coordinator roles are representative of an 8-year partnership between the Fred Hollows Foundation, CheckUP, Palm Island Community Company and Gidgee Healing. The partnership has enabled the funding, has funded the employment of 2 First Nations roles as dedicated resources in the delivery of community-driven eye health care to First Nations people residing in regional and remote locations. The role brings together local, cultural and professional knowledge to deliver culturally informed and safe eye care. Nicole's day-to-day work includes organising and attending outreach clinics, patient care coordination and community engagement and education. I'm going to channel my inner Oprah and we're going to use an interview style to have Nicole talk about the day-to-day, and we're going to talk through a couple of patient, de-identified patient stories to really exemplify the criticality of the role and the way in which this role works. Just to add, both roles work alongside the visiting optometrist that CheckUP funds to both locations. So Nicole, tell us a bit about yourself and your role.
Okay, hello everyone. So I am Nicole and I am from Mount Isa. I live there and I've been with Gidgee Healing for 6 years. I've been working alongside Locke and Tom, our optometrist and audiologist, for 5 years. And we visit, so 5 communities, just turned 4 recently. So Mornington Island, Doomadgee, Normanton, Burketown and Mount Isa. and we travel to each of those communities roughly once a month. We go out there. So rather than sort of just talking about exactly what we do every day, we thought we might just share some stories from clients from our communities, some good, some bad, and yeah, sort of just dive into that.
Who would you like to start with?
We'll start with Mr. Jones from Normanton. So this patient story of ours, so we'd been going to Normanton for quite some time, for a few years before we got to see Mr. Jones. We'd actually was seeing his wife for her eye test, and when we asked if she was diabetic, she said no, but my husband is, and he's overdue, and he keeps putting it off, as we all do. And he needs to come in. So we said, well, opportunistic is massive for us. We just see patients rocking in the door at any time. So we said, give him a ring, tell him to come in, and you can't say no because you're here. And so he did. He come in, had his eye test, and it wasn't great. He had a lot of bleeding in the eyes, diabetic retinopathy. We couldn't even get clear views on one of them, so we were not entirely sure exactly what was happening in the back there. So that required an urgent referral to the ophthalmologist. And as we know, Normanton is very remote. All urgent ophthalmology referrals, they have to go to Brisbane. So it's a lot of work trying to get the patients there, especially when it's going to be in the next day or two. So for me, my point is I will go take the patient to the hospital, Normanton Hospital, with a letter from the optometrist. Basically, just sit with them while everything's being arranged, while the hospital liaise with Brisbane, who are amazing, getting flights arranged, whether that's with RFDS or with like just commercial Rex flights. Once we have all that information and flights are booked and surgery or an appointment has been sorted, then it's up to me to help the escort, or in this case, Mr. Jones's wife, to then get flights, accommodation, request funding for taxi vouchers, out-of-pocket accommodation costs, food vouchers as well. A lot of hidden expenses when you have to travel so far. So he was able to get there. He was going back every month, and he was also seeing us when we would come to Normanton, just so we could see how he was going, get some feedback for him as well with his treatment. He was quite unwell. Obviously, what we've seen in his eyes was just a small indication of what was happening in the rest of his body. And after about 18 to 24 months, he was lost his vision completely. And going from a fully independent person, such a community man, to being basically disabled, was very, very hard on him and his family. Financially, mentally, his life had completely changed. And yeah, he passed not too long after that, for about 18 months. So it was just quite sad to see one of your patients that you get on to specialists, but it's the preventative wasn't as good as what it should have been. So quite a sad ending to one of our patients there, but we did everything that we could, and yeah.
I think you speak really clearly around the value of your role in supporting someone at such an urgent point in their health journey. And I think the real standout for me, we probably didn't hear a lot about, I think you talked a lot about your role and the day-to-day, but I'm curious about how you supported Mr. and Mrs. Jones actually through that process of going back and forth from Brisbane.
Yeah, so basically it was every time that they had an appointment, they would give me a ring, or the optometrist a ring, or they'd come into the clinic when we were there. And we would just make sure that they had sort of all the support they needed. So if they needed taxi vouchers, they needed food vouchers, if they needed transport to the hospital to be picked up. And it was just sort of being available when they were there as well. Heaps of things arise. Your flights can be delayed, so you're getting in at 10 o'clock at night. So there's just so many different things. The support doesn't stop just because you're out of that community. It just continues that whole journey until, they're sorted. Yeah.
And a fair bit of emotional support for the couple.
Yeah, 100%. As I said, the financial stress, as well as everything, especially on Mr. Jones's wife, having to take time off of work, and things like that. So for her to be able to talk and and just release a bit of the stress. Because obviously she's there to support her husband and their kids. So to be able to talk to us, you know, when we would come in every month and just give us an update was I guess helpful for her. Yeah.
Thank you for telling that beautiful
That's
story.
okay.
I know you have another one about Miss Millie.
Oh yes. Okay. So a bit of a happier story. Miss Millie, a client in Mount Isa of ours. She's actually from the NT, and she come to Mount Isa, I think early 2000s. We actually seen her when we were doing a home visit to one of their homeless facilities in Mount Isa. And when she walked in, she was holding onto someone's shoulders, and we thought, "Oh my God, great! This is just what's happened to this poor woman." We thought she was just completely blind. It turns out she just had really dense cataracts. Come to find, she had been referred, I think, 10 years before we had seen her, and she has just been in and out of the system, failed to attend, referred back to this person, sort of just missed. So we ended up actually doing a referral to Brisbane. And trying to find an escort to get Miss Millie to this appointment was just horrible. She had no family in Mount Isa, and her friends at the shelter were unable to assist her. We actually had a staff member from work take time off to take her to Brisbane to get her surgery done. So we got to Brisbane after arranging all the flights, accommodation, taxi vouchers. She's gowned up, ready to go, waiting for theatre. The surgeons come out and say that they've had unexpected delays through the day and they won't be able to do her surgery. So we had to get her back to Mount Isa, rearrange it all again. Belinda, our lovely AHP at work that assisted Miss Millie, was able to bring her back down again. And it went well, and she's now, I see her around town walking on her own independently. She can shop, she can shower herself, and it's just great to see someone who has just fallen through for so long finally get, the service and the surgery that they need. Yeah.
Thank you
That's
for telling
okay.
that story. I think it talks to both the challenges,
Yeah.
not just the practicalities of outreach, but also some of the systems barriers that you work really hard to
Yeah.
be responsive to and think creatively around. Not just your role, but your whole team wrap
100%.
around your patients and your community to deliver those outcomes.
Yeah.
We've talked a little bit about some of the challenges of your
Yeah.
work. I think travel to specialist appointments is obviously one. I know from reading lots of your reports that contacting patients can also be a bit of a challenge as well. Can you tell us a bit? Give
Yeah,
us some
so
examples
obviously our communities are very remote, and a big issue is when you're trying to contact people from Mount Isa, and I'm trying to ring someone in Dormagee. Sometimes they don't have phones. Sometimes they're so transient, they're between communities. So having like the local staff, your AHPs, even down to your reception, just local in each community is the key to service delivery. It's the difference between seeing one patient and 50 patients. It's just, that local level, and their understanding to training them so that they know how the system works when a patient's got to go to Brisbane and all the little things in between is what makes a service.
I know that we're heading close to our finish time. So in closing, I'd like to really acknowledge that you do a remarkable job in some very extreme environment and really difficult circumstances at times. Can you tell us what drives and sustains you in doing the hard and continuing to do the hard work of outreach eye health care?
Yeah, it's definitely the people in the community. It's someone's mum, someone's grandma. It could be your grandma. You know what I mean? Just to see the positive outcomes that you do. And it could be something as dropping a pair of eyeglasses off to someone's house, and just the day that they can go to bingo and see the numbers. Like it is, those little things. And that's what everyone says. You're so lucky to have the eye health coordinator role, because as soon as you give out a pair of glasses, you're just the favourite. And I love that. But it's just, like Miss Millie and those things, and sort of the relationships you build, like Mrs. Jones's wife, someone you never forget and someone that never forgets you. So to help the patients and them also help you and remember what you're doing matters and why you do it, and it's important to remember that when you go, you're training the next person and the whole team to keep it going.
I know you're quite passionate about some of the systems level work that you're really seeing unfold as you're skilling up the team at Gidgee. Can you tell us a bit more about that and why that's so important to you?
100%. I feel, a big issue, especially where we are being so remote, is that your staff turnover is crazy. And we do get a lot of locums, which we are 100% grateful for. But it is, as I said, local training, your local staff, and keeping them there and investing in them is the key. And keeping them interested in, and eyes, for example, so many people show interest in it, and when they see like even a retinal photo of the back of the eye, they're just amazed. And so I feel like I've had a lot of AHBs interested in it, and to train them and integrate it better into your primary health care is really the goal. Yeah.
Well, that finishes us off very nicely. Thank you very much, Nicole. Thank you.
Sorry, while you guys are there, I just wanted a quick question.
Yeah.
Because obviously I'm originally from rural and remote. And when you talk about the tyranny of distance and seeing specialists, I can't tell you from a community perspective to have travelled 9 hours to see a specialist in Brisbane, and then they tell you, can you come back next week? Is there a mechanism to educate those guys? Because if there's the opportunity that they understand that tyranny of distance, and I don't know whether they do or they don't, or whether they care or they don't, but if you've got a patient coming from a rural and remote community, and you've got a patient who's here in Brisbane, I mean, to me it's a no-brainer, but it happens with a lot of consistency. Not only that, but then sometimes the public transport systems, or like for example flights, suddenly they cancel a flight in those small communities. The impact on those people, a lot of people from those communities, they're not on big wages. Any time that they've taken out of work has a huge impact. And so it's a frustration that comes up quite often. It's like, we've just travelled how far and you want me to come back next week? You've got to be kidding.
And that's the advocacy that these roles.
Don't get me started, please. I'll be here for hours. There's some amazing things like, Brisbane, rural Brisbane are fantastic. Like, we couldn't ask for more, better support from their ILO unit. And Yashni nurse now, if she's watching. But yeah, as you say, there's some big hiccups in it. And as you say, we have patients that cancel their appointment because pay week's next week, so they'll try and rebook it for next week. So there's lots of things, for sure.
But it's definitely something that comes up with some regularity,
100%,
and it hasn't changed. It hasn't changed.
Thank you.
Thanks, Michelle. Thanks, Nicole. There's one big backyard.
Yeah.
A lot of movement, so well done.
Thank you.
It was interesting to hear about the staff too, being able to keep them. So I imagine that's a big problem to try and address. So, all right. I'm assuming we're moving on to Philippa and not Mount Isa. Yeah, perfect. No worries. All right. So I just want to welcome up Philippa Hawke, who is our evaluation lead here at CheckUP. Does a great job. Philippa has had a diverse career spanning 35 years across government and not-for-profit sectors as a practitioner, service manager and evaluator. Over the past 5 years, she's led the evaluation of CheckUP's health service and training programs, beginning with the development and validation of a patient record experience measure, PREM, of cultural safety for Aboriginal and Torres Strait Islander patients accessing eye and ear surgical support services. So, hand over to you. Thanks, Philippa.
Okay, thanks, Tony. Hi, everybody. I will try and stick to time because I know we're already pretty much over it. And I know that evaluation is not everybody's sort of favourite game. But what I'm trying to share with you today is really a practical story about building evaluation capability in primary health care, because I come from a background in mental health and community services and family and youth services where evaluation is just standard. It's patient-centred, client-centred is just standard. When I came to work in primary health care, I was really shocked at how difficult it was to implement evaluation programs into primary health care. So that's what we've been struggling with over the last few years here, to try and find a way we can systematise it as much as possible to make it as easy as possible for our outreach providers to collect information from their patients around the kinds of experiences and outcomes that they're having. So this is a practical story about building evaluation capability. It's not a story about surveys. It's about creating the conditions for patients to be heard, for providers to receive those useful insights from their patients, and for organisations to act on what they learn. At CheckUP, we conduct multiple evaluations across multiple programs, and I've only got a few minutes, so I just want to concentrate on our major survey, which is collecting feedback on patient experiences and short-term outcomes. I call it a hybrid prem-prom because it's just 3 experience measures, 3 short-term outcome measures, and that comes from the fact that we as commissioners of service have very limited access to patients to be able to measure long-term change. We don't know who those patients are, so we can only really measure the short-term outcomes from the session that they've just had with their provider. So, this one. That one? Oh, yeah. Patient-centred evaluation extends obviously beyond measures of service activity. Activity is generally easy for people to collect. You know, it's how many times did you go out to a service, how many patients did you see, etc., etc. To actually then measure what the patient experienced through that process and what impact it had on their lives is a lot more complicated. It requires systematic collection of their experience and outcome data, interpretation within the service context, and then the application of that evidence to planning and quality improvement services of the providers. Patient-centred evaluation is person-related. It needs to be done in a safe environment. It needs to be culturally safe, private, and given sufficient time, availability, so it can't be rushed. And all these conditions are what adds to the degree of difficulty for evaluating outreach service provision when our providers are on strict timetables. They're travelling with a lot of equipment on small charter flights, and they really don't have a lot of time when they've got patients queued up down the block waiting to see them. So we have to try and make that as simple as possible. Just quickly, that the cycle of data collection and evaluation and the monitoring and reviewing is very similar to any quality improvement cycle. So we start with collecting the data. That data gets sent back to us here in Brisbane. We analyse the experience and the outcomes that the patients have had. We report those findings back to the individual providers wherever possible when we can identify who those providers were, and that's a whole challenge in itself, but we're getting pretty good at it. Then we include recommendations in those reports back to the providers, and then we ask those providers to implement any service improvements arising from what the patients have told us about their experiences. And then our stage 5 is our monitoring and review. We want to be able to monitor the impact of the actions arising from the patient's recommendations. So to do all of this, particularly stage 1, no single collection method is appropriate because we have such diverse patient groups and service settings. CheckUP uses multiple paper and digital options to improve survey accessibility. We offer a range of survey lengths. We offer support administrative processes adapting to the practical constraints of outreach delivery. So just very quickly, I'll show you. So that's an example of our long form. So here are our access questions. there are experience questions, there are outcome questions, and then there's some space for patients to tell us a little bit more detail so we can drill down around why they scored the way they scored. We have a one-page reply page form that doesn't require anybody to be, the providers to be mailing those 2 pages back to us. The patient themselves can take it home and then just drop it in the letterbox. Themselves, it still includes access, experience and outcome measures, but in a shorter form. And then we have this very short form of the postcard, which is by far the most popular with patients, and you can understand why. We all like short and to the point surveys. We do miss out on the qualitative comments, which is a bit sad, but we are able to give a general sense back to providers about what the experience and short-term outcomes have been like for their patients. We've got the first, I think CheckUP has got the first 3 stages of that down pretty pat. As I said, it's up to the providers then to implement the recommendations from the patients, and we have some ability to monitor any changes that they're making as a result of that. But I think that for us, and probably for most organisations who are trying to evaluate their programs, this stage 5 is the most difficult, monitoring the impact of the actions that have arisen from the evaluation. I'm sure we're not alone in that. We're just a very small commissioning entity, but I've been given to understand from a range of different stakeholders that we're still streets ahead of even large commissioning or entities, even just in those first 4 steps. Oh, and that's an appointment card we just put up this year, so the provider can write the next appointment for their patient, and our QR code for those patients who are interested in doing digital data, direct data entry themselves, can use that QR code to give feedback. Just flagging that's an old QR code. We've recently moved our data platform to Australian soil. Thank God, finally. So I've now got to change all the QR codes on all of our materials, but we'll get there. Okay, so what are the barriers for the providers? And there are many. The collection, obviously, of the data from their patients occurs alongside clinical activity, the travel, and their administrative responsibilities. It requires coordination of materials and devices, integration with their service workflows, monitoring of the returns they collect and getting them back to us, and lots of communication and follow-up between us and them. Providers regularly tell us that they value the patient feedback, but the collection competes with that clinical care, travel, and administrative other responsibilities they have. The survey itself might only take a few minutes, but the capability around it includes printing, posting, setting up the QR codes, the device setup. We have collection boxes for that we had made and sent out to all the providers, big things. So it was a very expensive postal process. Sending reminders, tracking, following up, and organisations who want to do evaluation well need to recognise and resource all that hidden work. The operational barriers that some of our providers have told us in annual surveys that we do with them. These are actual comments from the providers. You can see, is anyone can't read them? We're waiting for internal services support. Patients aren't hugely interested. They just want their treatment or their spectacles. If I have good admin support, I can get it easily, but in other locations where I don't have any admin support, I can't get it. And I love this one. I love the honesty. I just keep forgetting. So once we've got that feedback, how do we translate that into service improvement? So providers have described, again, several practical uses for the reports. They talk about their discussions with their staff and their clinical advisory groups. The results of their reports support accreditation processes for them, professional development, reflecting on whether they're meeting patient needs, adjusting experience actions such as the booking and the care processes, and demonstrating the value of the outreach services. And I've had so many providers say to me, thank you for doing this, because generally we only hear when somebody's really unhappy. To hear that our patients are actually really appreciative. I mean, we knew they liked us, but to see the hard data, the quantitative data of what things we're doing well, just keeps us motivated to keep going out there. So this is the return on the investment by the organisation. The patient voices become a management and a quality resource. These are some of the ideas and the uses that our providers tell us they're putting the reports to. So you know, our providers, some of them are just single solo practitioners, some of them are very large organisations that might have 40, 50 practitioners. This person said, as a solo practitioner, I primarily use the patient feedback for personal reflection. Other organisations have told us they discuss the results with the staff and the team about the values our clients get from our outreach trips and showcase to our communities the value of consistent care. I discuss with staff a review processes to help us improve our services and support. We use these reports to monitor trends over time, support staff development and enhance patient-centred care outcomes. It's useful for college professional development, tools for training, some really lovely examples of how the providers use these results. So how do you embed patient feedback within organisational systems? So how do we get there? If we're a statewide network, this is CheckUP, we're a statewide network of diverse providers, disciplines and populations across Queensland with a range of patients who have a range of survey and digital literacy. So the practical lesson is to build the joined up system around the survey with all partners in the network seeing the value and playing their part. Leadership in the organisation signals that patient feedback matters. Resourcing covers the hidden work. Workflow makes collection routine rather than an extra. Inclusion creates genuine access, and that's inclusion for the patients in the formats of the surveys. And just as another very quick example, we provide data collection, analysis and reporting services for the Vanguard IRIS team, who operate both in Northern Territory and in Queensland. And they recently asked us to amend our cultural safety patient reported experience measure to fit better for populations in the very, very remote Aboriginal communities of the Northern Territory where English isn't even spoken. So we did some work with them and created an additional format just for those populations. Yeah. What's the rationale? Well, like I've just been saying, in a perfect world, an effective evaluation system should use measures proportionate to the service context, allocate sufficient resources to administration and analysis, report the findings to relevant stakeholders, and then document the actions taken in response. And like I said earlier, I think the most difficult part is monitoring the actions that are taken in response. That's the bit that just requires an additional piece of resourcing that is hard to find. For CheckUP, so we've been using this format in our generic outreach program for the last 2 years, and to date we've had 1,118 patient responses. Those were sent in relation to 145 practitioners. Now, be aware that's not necessarily 145 providers, because some of these are multiple practitioners within a single provider. We've had 343 Aboriginal and Torres Strait Islander respondents to just that one survey, not counting all our other types of Aboriginal focused program surveys. We provided individualised reports to 52 times to providers, and the overall score for all of those providers has been a Net Promoter Score of 90, which is incredibly good. but not surprising. We know how much the patients really are impacted by these outreach services, and that's across 70 locations in Queensland. So limited evaluation resources are stretched across multiple programs that now require evaluation within CheckUP. And of course, the other additional problem is that increasingly over time, with customers and clients and patients being asked to evaluate everything you do, like you can't even go shopping at Coles without getting a text message saying, how was our service? So survey fatigue becomes a real issue. And I hope not, but I think it's only going to get worse as time goes on. So it is up to the providers to communicate to the patients that we're not just Coles, we're actually trying to deliver something really important, and it is really important that we know we're doing it well. The investment in the evaluation infrastructure for us hasn't increased the volume of patient feedback. So this year we had a little less number of responses than we had last year. But we included the short-term outcome measures and the preparation of individualised reports. Those have increased. And like I said, those reports are generally greeted with enthusiasm, and they lead to greater participation once the providers understand that the data will be returned to them and not just sit on some shelf, which is what generally happens in evaluation programs. The providers themselves rarely see the data again unless something bad has been reported against them. And then just very quickly, how do we use it internally? So for CheckUP, we have those 4 regions that Elisa talked about. So each quarter I will drill down the data to the regional coordinators level and pull out their own data. So those are the locations, for, as an example, for, that was yours, Central West. 203 patient responses, 15% Aboriginal Torres Strait Islander, 27% said they would not be able to access a similar service if those providers weren't going out there. These are the types of services, everything from psychiatry, GP, cardiology, exercise physiology, gastroenterology, paediatrics, all the way down to physio, OT and exercise physiology. These were the results. Patient experience, you can see how high the experience levels were, and their outcomes, their increased awareness about their health condition, knowing more about the things they can do to improve their health condition, and being more likely to take action to improve their health-related lifestyle. And if you want to have a look at more detail about what we do in evaluation, that's our website link to the CheckUP website that'll give you more detail about the results of all our programs. Thank you.
Okay, that brings us to the end. So, firstly, just want to thank all the presenters. Great work being done. In particular, Kathy, Nicole, and Sarah. All right, have travelled to be with us, so thank you very much for sharing your experiences. Bit of a chance now to open up for questions. Probably should have done it after each one, but we're at the end now. If there's questions online, please type it in. We can read it out. Alternatively, if we don't have time,
Questions over lunch, perhaps?
Questions over lunch, perhaps?
Because we are a little bit over time. Yeah.
All right.
Unless someone has a burning question.
Anyone? I do hope you join us for lunch. We are all around, so it would be good to chat. All right. Thank you for that. I was just going to add in for the evaluation piece too. It not only informs providers, but it's also a really key message to send back to funders around the difference that we're making, and that's where it's really useful as well. So,
can I just do a promo for our next session? So we do 4 of these a year. Our next one will be close to International Day of People with Disability, which is the 3rd of December. We're just setting a date, probably be late November. It's one of our most popular sessions of the year. They're all great, but I particularly love that session. Outreach was really good. Well done, everyone, by the way. I've been doing these QPHCN meetings for about 15 years. And they just keep getting better and better. And first time we've done an outreach one for a little while, so I think it was really great. So International Day of People with Disability, the next session, last one for the year. And I'm going to do a promo. We have a disability awareness course that you may or may not have heard of. It's called Access for All. We've just refreshed and relaunched it. So grab one of these cards if you're interested. There is a small fee to do it, but we're offering 25% off to QPHCN attendees. So when you put the coupon code, you type in QPHCN, which is the name of this meeting, and you'll get 25% off. So if you are interested in disability awareness, specifically for health providers, this is the course to do. Okay, and the cards are here, so grab one before you go. That's my promo, Tony.
Done well, David. You should have taken over my role, mate. All right. Thank you. I'll bring it all to a close. Thank you. Please hang around for lunch, have a chat with us. And to my team, fabulous. Keep up the great work. Looks great. Thank you.
Thanks, everyone.